Hello, welcome to Maternal Matters, Voices from Virginia, a podcast series hosted by the Virginia Community Healthcare Association. I am your host, Phillip Noel, and today I'm joined by Dr. Tonya Adkins, who is a Navy veteran, an OB-GYN, as well as the CEO of HealthWorks for Northern Virginia. And today we are going to be discussing access in maternal care. Dr. Adkins, thank you for joining us.
Good morning. Thank you for having me.
How are you feeling today?
I feel good. I'm going to talk about a subject that is very near and dear to me. So I'm excited to share my experiences and perhaps educate the audience a little bit about what we face in the OB-GYN field.
And I think that you are an ideal individual to have this discussion with, honestly. And so for anyone who may not have been aware of the work that you have done already, give us a little bit more about your career background and also your work now with HealthWorks for Northern Virginia.
Absolutely. So I grew up, Phillip, knowing I wanted to be a physician. You know, my grandmother, who I spent a lot of time with growing up, she had a physician who loved her. And we're talking the 1970s, right? So he was an older Caucasian man, but he adored my grandmother. And he always addressed her with respect and dignity. And I would go with her to doctor's appointments. And one day I came home, I said, Mom, I'm going to be a doctor when I grow up because I want to take care of grandma. And from that point forward, my parents propelled me to becoming a physician. Everything I did was, well, you got to do this because you want to be a doctor. So fast forward, college, medical school, and then residency. And residency medical school had a profound effect on my career. I went to a historically Black medical school where we learned not only the art of medicine, but how to treat people. And that had begun when I was a child, grew up in a very caring family. But there's a difference between coming in and seeing patients and coming in and caring for patients. And I think that being at Meharry taught me that. It taught all of us that. And I think that's a lesson that's not being taught today.
Yeah.
Leaving Meharry, I went to residency in inner city Baltimore because at that time I had a desire to take care of pregnant teenagers. And at the time, Baltimore had the highest teenage pregnancy rate in the country. My mom was a teen mom, and I knew that was just something I wanted to focus on. So inner city Baltimore, early 1990s, there was a lot going on.
Sure.
And it was really trial by fire.
Yeah.
I had a lot of great experiences. I saw firsthand disparities in healthcare. I saw firsthand the mistreatment of women because of poverty and differences in race. And it was at that point that I said, I want to make a difference in this field.
Wow. And now that it's brought you to the door of being now the CEO of HealthWorks for Northern Virginia. And so what is the important work of what you all do there every day?
So I really thought I was influencing lives when I was a physician. Mm-hmm. But now as the head of a federally qualified health center, my reach is so much bigger. I get to influence the providers and the care they provide. I get to influence policy. Every day the impact that I have is astounding. At federally qualified health centers, our mission is to care for the underserved. And every day we live that mission. We have 5 locations across Northern Virginia, 2 dental clinics, an imaging center, and we provide care to about 17,500 patients a year.
Wow.
That may not sound like a lot of patients, but in a year, we have about 62,000 visits.
Surely.
And none of those patients ever fear that they're going to be turned away from care.
Gotcha.
Because our purpose is to take care of them.
And again, your background, as you already spoke a bit about, you've had experience in the military and in private practice and now leading a nonprofit clinic system. How have all these experiences helped craft your perspective and even like your leadership capacity with the work you do?
I think my experience in the Navy taught me a lot of things. That's where I learned that leaders eat last, that you lead from the front, that you lead by example. It taught me some hard lessons because in the military, especially then, there were very few women of color in leadership positions. And when they chose me to lead the OB-GYN department, I was astounded.
Yeah.
But they had tried it other ways. And they saw something in me that said she's going to do a good job. because she's going to be fair and equitable. So it taught me a lot about leadership.
Yeah.
When I went to private practice, I think I enjoyed my patients, but they didn't need me in the capacity that I wanted to provide care.
Okay.
They had choice.
Yeah.
And after a few years, I realized I wanted to go back to my residency roots and take care of those patients who may not have a choice in who their provider is.
And that kind of leads us into the conversation of access, right? And so to you, what does access mean when it comes to maternal care?
Access is how quickly can this patient get in without having to jump through a whole lot of hoops to be seen.
Right.
Simple as that.
Yeah.
Can we get in without having to call 5 people, beg, borrow, steal?
Yeah.
That's access.
And so ultimately, what drives some of those challenges? Again, so for speaking of Black women or Spanish-speaking women, what maybe drives some of those challenges that are faced when it comes to access?
Of course, poverty, transportation, childcare issues, language barriers. Those are all the things I've seen in my career, but especially in where we practice now.
Yeah.
Often women don't have a car. They have to borrow a car. If they have multiple children, they have to find childcare. If they don't speak the language, they may not be able to communicate their needs as clearly as they could if they spoke English.
And can you speak to a bit of the demographics? So again, we're Northern Virginia. It's a pretty big space. So what's the scope of the area that you all serve with HealthWorks?
So with HealthWorks, because we're a federally qualified health center, we typically take care of those who are underserved. And in Northern Virginia, that's often those who are of an immigrant background. They often speak a language other than English. They are often, well, not often, 96% of our patients fall below the federal poverty line.
Wow.
And so those are the barriers that we faced in taking care of those women.
And so in the U.S. also, for people who may not know, has the highest maternal mortality rate, which is just, of course, terrible. And especially, again, for women of color. And so how have you seen that show up, even in your time as an OB-GYN? How have you seen that challenge and that issue show up in the day-to-day work?
In so many levels. The first is often as women of color, we are the strong ones in the family, right? We're the center of our family. And so we don't take the time to go get care until it's too late. Often when we do try to get care, our concerns are not taken seriously. And because we don't have people advocating for us, often the care that we get, I hate to say substandard because I don't think any provider sets out to give substandard care. Sure. But I think because of some of the conscious or unconscious biases, we often get substandard care. Because of our stereotypical strong woman, even some of the stereotypes about our childbearing and our sexuality, all those things get in the way of having good care provided.
Yes.
So.
And 2/3 of those maternal deaths happen after delivery, right? And so can you just speak about what that very sensitive time block is, the weeks and months after a woman has given birth?
Certainly. During prenatal care, you have approximately 8 to 9 visits, right? So that's a lot of doctor's appointments.
Surely.
You deliver your baby, you go home, you think, I have a healthy baby and I'm doing okay. Yeah. And then you kind of think, do I really need to go back for my postpartum care? And often you suffer in silence. And something I don't often share is that, as a practicing OB-GYN, after my first child, I had postpartum depression. Didn't realize I had postpartum depression. Because for the most part, everybody thought I was okay. Yeah. But I think had someone said to me, "Are you okay?" Yeah. I would have discovered that a lot earlier. And one day I just woke up and it was like a curtain that opened up. And I was like, wow, the last 9 months, a year have not been normal.
Wow.
But no one really asked me, how are you doing mentally? How's your mental health? So I think we just get into survival mode. We've got a baby. We might have other children at home. If we're not bleeding to death or in so much pain we can't go on, we just kind of ignore everything until it comes to a head. And by that time, it's often too late.
And so are the patients asking, even during that, like you mentioned, that those 8 to 9 visits prior to having the child, are they curious about like, hey, what does life look like after I do give this birth?
Things have changed so much.
Yeah.
Now we ask questions.
Mm-hmm.
When I did my training and early in my career, we made assumptions.
Sure.
But now at every single visit, we're asking, do you have feelings of sadness?
Mm-hmm.
Any thoughts of suicide? Are you eating? Do you have, sufficient food? We ask all of those questions that get to everyday life. And so we're less likely to miss those things. But sometimes if you don't have someone with you advocating,
sure,
you just assume, everything's great. But you might have an aunt who said, no, yesterday you said you hadn't slept in 3 weeks, So it's, at least now we're asking the questions.
Okay.
But we have to just educate our patients that we really do want to know the answers.
Right. And what are the risks of skipping those postpartum visits?
Perhaps sometimes we think that our bleeding is normal, or that our pain is normal, or that, the fact that we have, not returned to having regular menstrual cycle. All those things that we may think or perceive to be normal could be addressed in a postpartum visit.
Wow. And then going back a little bit to HealthWorks, right? So HealthWorks currently refers patients for prenatal care. And so what barriers do patients possibly face during that handoff process?
I think for us, we're a primary care space. And so we see patients, we understand them, we know what their chronic issues are. When we hand those patients off to someone else, we lose that continuity, right? The patients see their obstetrician for 9 months. And if their contraceptive needs have been taken care of in the hospital, we may not see them again for 6 months, a year.
Wow.
And so we lose the opportunity to follow up with them in a way that could be meaningful, because we've taken them out of our system, and now they may not come back until they really need us.
Yeah. Wow. And HealthWorks is one of these amazing networks that strives to not ever have to turn patients away, right? And so ultimately, what does it take behind the scenes to even make that reality come to life?
A lot of funding.
Mm-hmm.
Caring for patients is expensive. And because we're a federally qualified health center, our patients are seen, the majority of them, on a sliding scale fee.
Yeah.
To say that we turn no patient away means that regardless of whether a patient can present payment at the time of their visit, they're going to be seen. And sometimes we never see that payment. And so we have to have funding in place to be able to say, we're going to care for this patient no matter what.
Mm-hmm.
HealthWorks is in a unique situation because we are situated in 2 of the richest counties in the country. And thankfully, those counties recognize that although we have great wealth, there is also a segment of the population that live in poverty. And they have taken the initiative to say, we want to make sure those patients are not unseen and that they get cared for. And so they provide funding for us to do that.
And so, again, a lot of the health centers that you are helping lead are really operating on these razor-thin margins, right? And so that financial reality behind the scenes, even in the past few years, how have you seen that challenge either develop, get better, improve, more difficult?
I think the COVID-19 pandemic shed a lot of light on disparity in healthcare. And during that pandemic, the government, local, state, they were eager to make sure we were taking care of patients. And so they provided a lot of funding to us to take care of those patients. And I think community health centers were very excited to have all this additional funding. And so we set out to do the things that we'd always wanted to do. Maybe we needed to open a new program or open a new site, and we used that funding to do those things.
Right.
And then when that funding came to a halt, we said, whoa, wait a minute. Like we've started doing all these great and wonderful things, but now where's the money going to come from to continue to support that?
Yeah.
And so many of us are facing a crisis on how we keep the wonderful programs that we established running.
Sure.
HealthWorks, because we have an extremely high uninsured population, we've always been a little bit more fiscally responsive. So when we got that funding, we did not open any new sites. We did not start any new programs.
Yeah.
We used that money to take care of our patients so that we could kind of put aside some money for the future.
For sure.
That was a good thing because as we face challenges of cuts in Medicaid, more uninsured patients, with the loss of ACA tax credits potentially, or it's happened. Hopefully they'll bring them back. We knew we were going to need money to take care of those things, and so now we're not in as precarious a situation as maybe some others who didn't do that.
Sure.
Every single day we have to make choices about how we spend our funds, and ultimately we want to spend our funds on patient care and not all the extra bells and whistles that would be nice to have, but often we go without.
And so we hear a lot about the uninsured, but there's a component as we also begin to hear about the underinsured as well.
Sure.
Can you speak on what that is and maybe what goes into?
So often, healthcare is expensive.
Yeah.
And so often patients will choose a healthcare plan that they have high deductibles, they have high copays that they can't afford. And the nice thing about Fairly Qualified Health Centers is that we offer a sliding scale to all of our patients. Every single one of our patients get qualified for a sliding scale. And so if you have a high copay insurance plan, but you fall into our slide, we waive those fees. And I think that that's important because people don't realize that you may have insurance but not go to the doctors because you can't afford the $75 copay. Right? So you've got this great program, insurance, but you can't use it because you can't afford to use it.
Yeah.
Right?
Yeah.
And so that's where we come in.
Yeah.
We take care of those patients as well.
And I think that this conversation was important to speak about the systems that are in place, right? And the financial challenges that the systems are dealing with. But to lean back into the people aspect of this work, including staff, right? Burnout. I can only imagine that this is probably also in an emotionally wearing work to do when you're dealing with patients who, again, you probably have stories from years now that you've seen of like, wow, like this is something we have to get better on. But can you maybe speak to a little bit about, again, your journey and what you have seen in the past? It's like, hey, this is what really attributes to what we think of burnout in the healthcare space.
So, I always tell people burnout is real.
Yeah.
When you are charged with caring for someone else's life, that's a high stress job.
Yeah.
Right. And I think as providers, we often don't realize how stressful it is until we hit a wall.
Mm-hmm.
I have seen things in my career that I carry with me every day.
Oh.
My first maternal loss, I can tell you every single detail of that story because there were things that we should have done differently. And you carry that with you every day.
Yeah.
When you go on vacation, you're still thinking about Mr. Jones's labs. Is somebody going to look at those labs? Are they going to call Mr. Jones like I would to make sure we, change their medication?
Mm-hmm.
My patient came to see me on a Friday. It's now the weekend. Is she going to be okay over the weekend? You don't turn it off.
Yes.
Right. And not just the providers, but even the staff,
Mm-hmm.
They care about our patients. And so at 5:00, you don't just turn that off.
Yeah.
Right. You carry it into your personal life. It wasn't until I stopped actively seeing patients that I realized what a burden it was.
Wow.
I came home that day, the last day I saw a patient, and I thought, wow, I don't have to worry anymore,
Yeah.
And I had been doing that for 27 years.
Yeah. And as you mentioned, you might look up and some people they've been pushing it hard ever since COVID.
Mm-hmm.
And now, we're in 2026 and like you said, may not even fully realize that that's something that they are dealing with. And again, the numbers are just tough even when you think of Black women who are 3 to 4 times more likely to die from pregnancy-related causes than white women, even when education and income are similar. Can you just speak to just one, that reality to someone that might not make sense when they hear that, but like, why do you think that is?
So Phillip, this is something that is very close and personal to me. I talked about my first maternal death. 20-something woman, African-American woman who comes to the hospital. She's got children at home, a husband. She comes to the hospital with signs and symptoms of preeclampsia. I admit her. I get her started on medication to treat the preeclampsia. I call my attending because I'm a resident, and I present my case, and he says, I didn't tell you to start her on magnesium sulfate. Turn it off. He said, I think she probably maybe has some GI upset. Let's treat her for that. Okay, I'm a resident. I'm looking at the woman. I know she has preeclampsia. It's a Friday. I go home. I come back on Monday. It's a holiday weekend. My parents are in town. Unfortunately, I have to go to work on Monday. And I walk in, and this patient is in a coma. We had taken her back to the OR. They had taken her back to the OR for an emergency C-section where she seized and subsequently went into a coma. Her baby survived. And I was devastated.
Yeah.
Why? Why did that happen?
Right.
I think, especially in the 90s, we're in a very patriarchal, medicine was very patriarchal. I'm a female resident. I call this male physician and I tell him what I think the case is. And he says, I'll be the judge of that.
Right.
Okay.
Right.
She subsequently died. And I will never forget that.
Yeah.
It took a long time for me to forgive myself because I should have demanded that we keep her on the medication until he came in to evaluate her. Fast forward 25 years. I'm an OB-GYN. I have a successful private practice. I have colleagues and peers who respect me, who care for me. Yeah. I'm pregnant for the first time. I'm old. Everybody's happy. And I begin to have some complications. And I know that something's wrong, but I'm good.
Right. Navy veteran.
I'm strong. No big deal. I can get through this. I've gotten through a lot of things in my life.
Right.
And I'm admitted to the hospital. I have severe preeclampsia. And no one wants to say the hard thing. No one wants to say, we've got to deliver you and this baby will not survive. Because they care about me, right? So it took someone from the outside to come in and say, if we don't deliver this baby, she's going to die.
Yeah.
And even then, I'm like, can we just wait a few hours till my husband gets here? Can we, and he said, no, we've got to start now. When I look back on that, I said, why? Why did it have to get to that point? Yeah. Why did at some point before it got so severe, did someone say, hey, let's take care of this? I talked to countless women. I was recounting that story to my leadership team yesterday when I was telling them that I was going to be talking on this podcast. And I got a message from one of my leadership team, and she was sharing her same story. Mm-hmm. African-American woman, successful, and she experienced the same thing.
Yeah.
So we know a couple of things. We know that this is not a one answer fits all. It's a multifactorial problem.
Right.
Because it crosses socioeconomic, educational, there's nothing that prevents it. Age.
Sure.
So we have to attack each of those things separately.
Right.
So the first is, and I don't talk about this often but the research is there. I think Black women face microaggressions that happen over the course of our life that have an impact on our physiology.
Wow.
That increases our blood pressure, our risk for cardiac disease. And so we have to factor that into the equation when we're taking care of African-American women.
Okay.
2, I think there are unconscious and conscious biases that we all have. And I think we need to start educating people at a very early age about how we overcome those biases.
Yeah.
I think there are cultural differences that keep us, again, consciously or unconsciously, from treating people the way they should ultimately be treated.
Yeah.
And so we have to attack this. And I think there's poverty.
Sure.
That's poverty and access.
Right.
So that's 5 things right now,
Right.
that I think we have to address when we talk about how we fix this crisis. And without addressing all of them,
Mm-hmm.
we won't ever solve the problem.
Right. And to that point, I think that there is a level of trust that you need to build with the patient, right? And so when you're thinking about race, or as you mentioned, some of the socioeconomic aspects or language barriers, that there's trust sometimes needing to be built, especially maybe if it's their first child. What is it that you have seen as like really good practices that you're able to build that comfortability with your patients, that they do begin to say, okay, I trust my provider?
People always look to, well, we don't have the same lived experiences, right? But respectful and compassionate care is a universal language.
Absolutely.
It doesn't matter what language you speak.
Absolutely.
It doesn't matter how much money you have in the bank.
Yeah.
Everyone deserves respectful and compassionate care.
Yeah.
And so walking into a room, remembering that this is a person who may have different lived experiences than you, but they still deserve the same, level of care.
Yeah.
I have seen in my education and in my career, the difference in the way people are treated based on their race, their income level. And I know that some of it is unconscious, but I've also seen it just be conscious bias. I think when we start teaching our providers to treat everyone the way their family would want to be treated, or the way they would want someone to treat their family, I think we start bridging that gap. And so I tell my staff all the time, treat everybody like you would treat your favorite relative.
Wow.
Because sometimes it's not the mom, your favorite relative.
Yeah.
You want to treat everybody like that.
Yeah.
And I think it's not until we start demanding that everyone be treated that way that we solve the problem.
And is that what you would say with probably one of those mindset shifts or mindset approaches in the work that you all do, that it's like, hey, this is how we can better serve our community, as if we have that mentality of, like you said, treating them like family.
Like family. And also giving them agency. No one knows their body better than the person who's...
True.
So giving them agency to say, this is how I'm feeling.
Yeah.
And hearing what they say versus saying, I think this is the way you're feeling.
Wow.
We got to give our patients agency. We have to allow them to be a partner in their healthcare treatment.
And this has been an amazing conversation. So I appreciate your perspective and sharing the stories with us. And as we go further into 2026, when we think of potential policy impacts that are being made on this field that you're so passionately within, Virginia has expanded Medicaid, for example. So I'll even just pause there. What impact does that have on the community that you serve?
I want to commend Virginia and all of the states that have expanded Medicaid. That was a real game changer.
Yeah.
It allowed people who otherwise would not have insurance to get insurance. I want to specifically call out Virginia for their Medicaid for Moms program, which allowed any pregnant woman meeting financial or income levels to have prenatal care.
Yes.
Game changer.
Yeah.
Because as a federally qualified health center, many of our patients were not eligible for Medicaid.
Man.
But now they all are.
Yeah.
Right. So there's really no reason that any woman who is pregnant should go without prenatal care. I'm going to give them another shout out because they not only said we realize it is important that they have prenatal care, but then they said instead of 60 days, we're going to give them 12 months. So 12 months, because you said 2/3 of all maternal morbidity and mortality occurs when postpartum.
Yeah.
So now they have 12 months of insurance where they can get care. That's amazing.
Right.
There are still 10 states that don't even have Medicaid expansion. And so those are the policy changes that we have to put into effect in order to solve this.
Right. And I love to hear that you point out things that Virginia is doing amazingly in, right? Or that they're making improvements towards But again, you're also an amazing advocate for this space. And so what are some things, even over the next year or two, that you're saying like, hey, we can go even further with this?
Absolutely.
Let's see about changing or improving this thing.
Well, of course, funding.
Mm-hmm. Of course.
Recognizing that without federally qualified health centers, there will be people who go without care.
Yeah.
So cutting our funding is probably not a good idea. Mm-hmm. We need more funding so that we can do some of those things that we think will improve overall health. Now, we're going to take care of our patients. We always do. But there are things that we would like to do better or do more of. And so funding to allow us to do some of those things would be wonderful.
Right.
Not taking away services. Let's not go backwards.
Yeah.
Right. Let's not take away those programs that have been proven to be successful. I think we have in Virginia at least, we're about to have a new administration.
Mm-hmm. Yeah. And
so I am hopeful that this administration will continue to recognize the importance of what we do.
Right.
And help to strengthen strengthen the work we do.
And what impacts or influences could further investment in either workforce or even infrastructure have on this work?
We talked about burnout earlier,
mm-hmm.
right? So in many health centers, there's a lot of turnover.
Yeah. Wow.
People think they come, when I interview all of our providers, mm-hmm. and the first thing I say to them is, do you really want to be here? This is really hard work. Do you really want to be here?
Yeah.
Because 9 times out of 10, it sounds good to say, I want to go take care of the underserved until you do it.
Yeah.
And once you begin to do it, you realize this is really hard work. Mm-hmm. I'm not just taking care of Miss Jones who has hypertension. I'm taking care of Miss Jones who has hypertension, diabetes, is obese. And by the way, she doesn't speak English, right? So I have to communicate all these things to her. She may also have cultural differences that when I say, you need to watch what you eat may mean something totally different from another patient, right? So there's a huge investment in taking care of our patients.
Yeah.
And after a while, it becomes very burdensome. And so staffing, training providers that want to work in this space is important. And in order to do that, we got to fund them. We got to pay for their education because you can't pay student loans, at least for medical school, working in community health. It's very difficult.
Okay.
And that's why we see a shift out of community health.
Yeah. And final question is for you. When you wake up in the morning and you go into the office to do the work that you all are doing for HealthWorks for Northern Virginia, what are maybe 1 or 2 things that you're like, I'm really excited about this?
This is going to sound so cliche.
I can't wait. Please.
I love my job.
Uh-huh.
I just love waking up and going into the office.
Yeah.
My staff will tell you, I don't like working from home.
Mm-hmm.
I like going to the office. I like being with the people.
Yeah.
Man, there are some days that so many things go wrong. But at the end of the day, I have to remember all those things that went right. The impact that we've had on people's lives, despite all the small things that went wrong.
Sure.
At the end of the day, we're taking care of people and we're doing a good job at it.
Love it.
So
awesome.
Every day.
Yes. Amazing. Well, Dr. Adkins, I appreciate you for coming in. This was an amazing start to what will be a furtherance of a series. And so again, thank you for making the trip first and foremost, and thank all the viewers who were able to catch this episode. We have a couple of more where we'll be actually speaking with a patient as well as a policymaker in this space to really help bring this whole series together. So thank you for watching, and we hope to see you again soon.